Okay, so 2 minutes past. We've still got people coming in. We're up to 27 now. 28. Excellent. Okay, so I'd just like to welcome everybody to the joint meeting of the Chew Valley and Soma Valley area forums. This is the first time we've actually done a joint meeting like this, and it's thanks to the technology of Zoom that allows us to do this. So it's really great. So we've got people from all over the western part of Bath and North East Somerset. So it's really great. So thank you, colleagues, for joining the call tonight. We've got a fairly tight agenda because we've got quite a few guest speakers. So it's really great that everyone's able to join us on the call today. Just remind everybody, basic Zoom etiquette and housekeeping. Everybody's to keep the microphones on mute unless they're actually speaking. We are recording, so you will have had a little thing coming up saying we're recording the session. The reason we're recording it is we'll put it out on the Baines. Does it go on the YouTube channel or the Zoom on the? It goes on. I think it goes on the Baines YouTube channel.
It's our YouTube channel, Chris. Yeah.
Excellent. Okay, thank you. What we're going to do is we're going to have. We've got 5 people speaking. We're going to go through everything that they say. So if you can, and then we'll have a question and answer session at the end, like a panel session. So if you can either keep hold of your questions, or you can put them down in the chat as we're going through, just in case you think you might forget it, or you've got something that you want to bring up at that point. So we'll keep an eye on what's going on in the chat, and then at the end of the session, there'll be an opportunity to hear everybody's hear what people say and ask them some questions. And then at the end, Linda and I will hand over to our vice chairs to conclude the meeting. We're going to be finishing at 7:30. There will be an opportunity for those who want to sort of stay on and chat for a few minutes later to have a little bit of a conversation later as we stack the chairs up and wash up coffee cups and stuff as we do at the end of every meeting. Oh no, we're on Zoom, aren't we? So we won't do that. But you know what I mean? We'll have that opportunity. But we did want to give people a chance, if they need to go off at 7:30, it's absolutely fine. That's when the formal meeting will end. And we'll press the stop record button as well at that point, if that's okay. So I'd like to say thanks very much, everyone, for coming. And I'm going to hand over to Linda.
Oh, thanks. It's all right. I was just unmuting, and it takes some time sometimes, doesn't it? Yeah, well, it is lovely to see everyone here, isn't it? The number of people who've booked in is great. So, but unfortunately, of course, we have had some apologies. So I've got a list of them here. Councillor Doug Deacon, Councillor Liz Hardman, Councillor Eleanor Jackson, Councillor Richard Robertson, plus the West Harptree Parish Council, and Liz Richardson, which is sad that they won't be able to be here, but that's how things are. So we're shortly going to our main theme of health and well-being and hearing from the key organisations which are delivering the services locally. So if, as Chris has said, if you could keep your questions until all the presentations have been given, this would be appreciated. The chat will be monitored if you wish to post anything there. Okay, right, so on to the main theme and over to Chris.
Right, thanks very much, Linda. So this is, you can tell this is a really tightly choreographed double act that we're going to be doing all night. So you're just going to bear with us on that. So first thing I'd like to do is I'd like to welcome Dr. Chris Lewis. Chris is a friend of mine and also a GP at St Mary's Surgery in Timsbury. And Chris is going to give us an introduction into work he's doing at St Mary's and to GP services in general. Over to you, Chris.
Thanks, Chris. Watching the double act is like watching the Eurovision Song Contest being hosted. It's amazing. So good evening, everybody. My name is Chris Lewis. After many years of attending the Chew Valley Forum, it's a real privilege to be invited to speak. So thank you for having us. I've noticed over the years that when a doctor speaks at one of these things, there's potential for us to be asked some awkward questions. So if you've got something that hurts or a bit of an odd rash, if you could just hold it up to the camera right now, that would save us a lot of time. I've been a GP in Timsbury for nearly 20 years, and one absolutely surefire thing that's been guaranteed for the entire time I've worked in the NHS is that it's in a constant state of change and reorganisation. In the early 2000s, it was primary care trusts. In 2012, you might remember the rows the coalition government had when they were bringing in clinical commissioning groups. And right on cue, we're on the cusp of yet another significant reorganisation of the health service with the promotion of what's called integrated care systems. What does that mean? Well, the idea in a nutshell is for primary care, so that's GPs, community services like Virgin, voluntary sector organisations, and the secondary care hospitals to work together differently, hopefully closer, hopefully better. And I think we're going to talk a little bit about that later on. But what that means for our locality is that the 9 GP practices around the Soma and Chew Valleys have come together as members of a new type of organisation called a primary care network. Now, this isn't the first time we've worked together. 20 years ago, we used to share the out-of-hours duties from Polton Hospital, for those of you who have long memories. But the new network formalises those relationships and opens up some opportunities to deliver care in our rural setting in new ways. It will not surprise you to hear that a global pandemic has placed immense pressures on the whole of the healthcare service from top to bottom. And this evening, you'll hear from Joe Scammell from Virgin Care, that's the organisation providing our community services locally, from Simon Allen from Age UK in Baines, from Denise Perrin, our very own Denise Perrin, who will talk about the work of the village agents, and Helen Harris, who is the manager of the Three Valleys Primary Care Network. And they'll talk about how all of those organisations have weathered the storm that was and still is COVID-19 and some of our future goals. And at the end, I've got the poison chalice of trying to explain to you why it's so flipping difficult to get a GP appointment at the moment, what we're trying to do about it, and honestly, what you can do to help us to help you. One more thing before I hand over. We in the health service are really terrible for using jargon and particularly acronyms. And if you don't know what they mean, it can quickly become pretty indecipherable. So if I catch any, I will try and add them onto the chat channel. But if there's a word or acronym you don't understand, please pop it in the chat and I will try and respond. So I'm going to hand over to Joe.
You're going to hand over to me, and I'm going to be so paranoid about these acronyms now, Chris, that I'm not going to be able to to concentrate particularly well. So I pre-apologise. I was one of those people that hated acronyms and then found myself starting to use them. I'm just going to give a bit of an introduction. I know that time is tight and we've got about 10 minutes. Is that right, Chris, or less? So I'm going to talk to you about overall our services and which ones we run, and I'm going to focus a bit on some work we've been doing with other partner organisations on this call around wellbeing, because I think it's one of the good things, dare I say it, to come out of COVID and the pandemic is, as Chris was saying earlier, some of the challenges around yet another reorganisation, but actually this one is encouraging people to work closer together, and actually that will benefit us and the people that use our services in our communities. So it is yet another bureaucratic reorganisation, and yet this one feels just slightly different because it's encouraging everyone to put down their organisational boundaries and work closer together. And I think we've got some good examples of how that can benefit people. So as Chris kindly introduced me, so I'm Joe Scammell and I lead the Bath and North East Somerset community services on a day-to-day basis. So those are adults health services, and I believe I came to a physical meeting when we first started the contract, Chris. I think that was a couple of years ago. So we run all the kind of out of hospital services that aren't primary care, your GPs, and aren't the hospital. But we do also have Polton Community Hospital and St Martin's Community Hospital in Bath. And it's good to know, Chris, there's still some shifts going at Polton Hospital if that's what you'd like to carry on or pick up the mantle from that. We also run the adult social care services and adults learning disability services and children's health services. And at the moment, there's big immunisations programme as well. So children's health and a lot of wellbeing services. which we'll talk about today, and partnerships with the third sector, and we oversee some of the contracts on behalf of Bath and North East Somerset Council for the third sector. So I think, as all my partner colleagues will say, it's been an incredibly challenging 18 months or 2 years now for everybody involved in the health service. And I'm very proud to say that we've kept all the services running during this time. We had to do some redeployments very early on in COVID. We had school nurses going back to work on the wards and things, but during the second lockdown, we have kept all of our services open, and including the planned services. And that's been a real testament to the teams working under very difficult conditions. Not to say that some of the waiting lists aren't larger than we would like them to be, or despite best efforts, and that people are still trying to find their feet in terms of this balance of digital interactions versus going to see people in person. But we do have a lot of services like district nursing who have constantly gone out to see people. And I think at some point we're the only people going into people's homes in the pandemic. District nursing still going into people's homes, still crossing a threshold and supporting vulnerable people in their own home. And I'm happy to answer any questions about those. Now, some of the challenges at the moment that we're experiencing may come up in the panel session, in particular at the moment, are around people coming out of hospital and people being able to be supported to get to their own homes. There is a distinct challenge around carers, and I think this might come up in conversation later, around our ability to safely get people home and then hand them over to care providers. And those providers at the moment just don't exist. So it's really, really difficult. It's probably more difficult now than at any point in the last 18 months for our system in COVID in terms of the wider health and care system. It feels very much the most challenged it's been, I would say. And I'm sure that others on the call will agree. And we are working very hard to keep things going with all of that balance. But it'd be good to possibly discuss some of that in the panel session. And one of those things has been the development of the Community Wellbeing Hub. So in COVID, without going too far into the background, we came together with a third sector group with organisations like the West of England Rural Network, Your Village Agents, the first responders, the wider volunteer services, and with the council. And you can see Sarah is on today. And so Sarah, Dixon, myself, Alison, who's probably on the call, we're all co-located now. We sort of live in the same, you can see the nice glamorous Dorothy House background. We came together and we set up a COVID response service, which has proven so popular that we are keeping it going and continuing to work together. So based in Peasdown in terms of physical part, but working with partners across the sector, we have got about 13 organisations and voluntary sector organisations that are now part of the hub. So it's set up to have one number, the information about not repeating your information twice, and be able to call and ask us about anything. And Sarah can probably say this off the top of her head, but we had about 13,000 calls since March. We've now got about 15,000 calls, and we have explained here that people felt much better after calling the hub. So the idea is that you call in, and whether it's food or food and money or food and money and health, there are all the providers at the first in the same building and now digitally that can help you and support your needs. So we would receive a call and say, well, actually, I have no food and no money, and I have a long-term. And we're able to say, well, first of all, we'll get an emergency food parcel out to you by, say, the first responders in your area. And then one of the team will talk through welfare and maybe a benefits review from Citizens Advice. And then we may need to contact your GP and let them know what we've been doing, or we go downstairs and talk to a health and social care professional. So we're all in one place working together. And as I said, that started off being a COVID response, but it's very much now talking about, we had a meeting with some colleagues on the call today around how can we support people now to get home from hospital safely? How can we avoid that next person needing to go into hospital? How can we support them to stay at home longer? And really being that glue and making sure that people don't have to repeat their stories again and again. So I think the next slide, Sarah, I don't have too many slides. So we've just talked about the current, we call them kind of response pods. So we don't say actually it needs to be citizens advice or clean slate that deals with the money matters. We just say in triage, actually, do you know what, housing team, this person's main issue is housing, who's going to be the best provider to work with someone around the housing, and then they pull in the other providers as they need to. And believe it or not, that didn't really happen as much pre-COVID. It happened more in the Chew Valley because of your wonderful village agents than it did in most other places. But across Bath and North East Somerset, the ability of us to share one system together, to share information, to work around people has been greatly improved. So Sarah, sorry, I'm going to just go on to the next slide, Sarah, so I can circulate these. So if you go on to the next one, on to 2 down. So we talked about a case study here where we had a retired nurse who was very vulnerable, who needed some complex health conditions, and Sarah and the council's team managed to get him some welfare, what do you call them, rubbish collection, sorry, it's late at night, being collected directly from his flat. So they go in and support him. We had Bath Mind who would support him with his mental well-being, and our health teams that then be able to go in and support this individual, managing safely to get him for his very complex operation and home again with some technology support and some health and care support. So it's a really good example of how people worked well together. And time is very tight, and I don't want to take up the other partners' time. So we have been working with the University of Bath to evaluate the hub and what it's done. And as I said, really positive feedback set from them about how people have helped each other, about how they've helped their communities, but again, how they haven't had to repeat their information in trying to access help. The main piece of positive feedback, I think on the next slide, Sarah, is around how partners have worked better together. So actually how we might know more about what the village agents do, and they might know who to contact about something else. And those relationships then to benefit our communities and the people that we're out there to support has been really great. I think in terms of summarising, in terms of the future, we want to continue this way of working. We want to expand what we're doing together to wrap services around people. We don't want to get caught up in too much of the bureaucracy, but we're hoping that that new change of organisation just allows us to put down some of those boundaries to support people no matter sort of where they pop up in the system, recognising that our communities don't differentiate between, you know, who is in Baines or who is at primary care and what's acute trust and all of the acronyms we spoke about before. And we're very hopeful that that will continue to improve and develop relationships. So it was a really quick whistle stop tour, Chris, but I did it in 10 minutes.
Joe, thanks very much. And also just, and I'm going to hand over to Linda in a sec, but just to say the other thing that you didn't mention is that on a bi-weekly basis, you've been chairing a meeting with all of the voluntary community sector organisations across Bath, North East Somerset, which has just been a really powerful way of both networking, keeping mutual support, exchange of information, sharing good ideas. And again, you know, it's something that has just been really invaluable to how we've approached this last 2 years. And your role in that has been immense, and in terms of keeping it going, in your energy and your commitment to that. So it's been really great to be part of that.
Thanks, Chris.
Linda.
Yeah, I was fascinated by that, I have to say. It's really interesting when you pick up information you didn't know before. So yes, what I would like to do now is move on to number 4 and introduce Simon Allen, who is the new Chief Executive of Age UK Baines, and hopefully he's going to explain more about the work they do and their future aspirations.
Brilliant. Thanks, Linda. And it's lovely to see so many familiar faces after a little while away from working in Bath and North East Somerset. So it's great to be back. I think what Joe's really helpfully kind of articulated is just how, in coming together, how much more we can do. And I think COVID has really shown that. So whether that's the first responders that are still going in one of the parishes through to what town and parish councils did, right through then to the wider charitable sector and to statutory services. By working together, we can do so much more. One of the things that I was really lucky to have already in place when I joined Age UK Bath and North East Somerset in May was a public survey that had been done before I arrived. And the whole aim of that was to understand how people in later life had experienced the pandemic, and what were the key issues that were affecting them, and crucially what needed to change. So if it's all right with you, I'd just like to start there and feeding back some of that information, and then move on to the services and support that Age UK are delivering. So if I can make the computer work, hopefully that should be on your screen now. Perfect. Okay. So just a bit of background to the survey. We put out about 2,000 of these surveys and had a 36% response rate, which in light of people being over surveyed often, we felt that was really good and really substantial in terms of that response, and meaningful in terms of the numbers. I've been kind of reacquainting myself with the area and understanding the demographics and our populations, and it was really fascinating for me just to articulate that there are just over 70,000 people aged over 50 in Bath and North East Somerset. So across Chew and the Summer Valley, that's about 20,000. I suppose the most interesting thing, and we've talked about an aging population for a very long time, but in the next 10 years, the over 75 population is going to grow by 36%, which is a significant increase and really positive in that people are living longer now. But alongside that, I think all of our statutory colleagues will kind of say that sometimes and will increase demand on services. I'm not going to dwell too much on some of these quotes that are here, but some of them are incredibly heartbreaking, but also incredibly heartwarming, some of them, because actually what we've seen is a real mixture in terms of people's experiences over the pandemic period. I suppose if I was to break down the kind of the key headlines, and there's lots of statistics here which I won't go through one by one, but I'll share these slides with you all. 48% of people feeling that they lost their confidence over the pandemic, and that sense of well-being was really rocked, and really important that people can rebuild that confidence. So I'm sure you've all come into contact with people in your communities who haven't shielded for so long, really struggling with that confidence to get back out into the community. 47% of respondents felt that they'd become more lonely as a result of the pandemic, and a significant amount of people feeling that their health deteriorated. But I think some of the things that really stuck out for us as an organisation in terms of what we need to do moving into the future is 65% of people really wanting to see more activity in the community that they can engage in and become involved in. Chris mentioned it, and I think Joe did as well, just around the use of digital technology and how that has really expanded over the last 18 months. And it was fascinating to see that quite a lot of people had used other technology other than their TV or their phone for the first time. So that increase in using some of those digital technologies. But I think what we're really concerned about, and I know this is shared across other partners, is that we just don't create a new level of inequality for people. There's quite a significant amount of respondents who really wanted support with digital skills. So whether that is being able to do your repeat prescription online, whether it is able to make an appointment for your GP through the NHS app, having that skills and that ability to do that really important. That won't be the answer for everyone, but clearly some work to do there. There was clearly some key themes coming through on the research, and I think this is really borne out by the work that the Wellbeing Hub has done and the value of joining together lots of different services. The key things around practical and physical access, practical wellbeing support, which we've seen that's been delivered right throughout. And then crucially, a really important one around how people are perceived when they're growing older, and what that means for people and their confidence and their general well-being. None of this will come as a surprise. I doubt. Things that we've long talked about, but clearly things that we still need to keep looking at and striving to do something about. So these were the top 5 that came out of the responses. Clearly, some more easily are dealt with than others. Rural transport, unsafe pavements, disabled parking, and I guess for some of these things, there are some things that we can do quite quickly. So actually making sure that we do protect our disabled parking so people can utilise it, etc. But these were the things that were really coming through for people. Practical well-being, I think I've already kind of talked about this, but I'm a social worker by background and I've worked in the NHS for the last 6 years or so. And the one thing that I keep coming back to is this concept of well-being, which is defined in the Care Act, and really crosses all those boundaries across health, social care, and all of the things that are happening in the Community Wellbeing Hub. And actually seeing the person as, in a holistic way, in that it isn't just a health need, it isn't just a social care need, but it is much broader than that. And actually, Jill mentioned we were on a call earlier today looking at the support that we could provide to support people home from hospital. And that was essentially that. So without giving away too many details, it was from how do we get somebody the practical physical care that they need, through to who looks after the dog and who delivers the meal. And all of those things make up an individual. So really important that we make sure that we take note of all of that. Perceptions were a really key thing, and I think what was really interesting is just people's perceptions of growing older and what that meant, and how I guess we can support people across Bath and North East Somerset to age well, and for aging to be as positive an experience as possible. Now, that's not always going to be possible in every situation. Life isn't just like that, but that feeling of being appreciated in society for the value that we all bring to our communities, and people not feeling that they're forgotten and ignored. And I thought I'd put this last one in for, seeing as we're at the Chew and Summer Valley Forum, the Baines being a bit too Bath centric, but I won't dwell on that too long. There were clearly some real positives that came out of the responses that we saw, and this is just a really lovely example of actually that time in lockdown where actually relationships were able to renew and reform. So it's clearly, there were a lot of people who found positives during that whole lockdown period, whether that was that they became volunteers themselves and had real purpose in terms of being able to respond in the community, or indeed for people who started to do new things, where a whole new area of opportunity opened up. And certainly from an Age UK perspective, what we found interestingly is that we ran some groups online on Zoom for people with mild to moderate dementia that were really successful. Potentially a group of people with a condition that we might not have felt that might have been beneficial, but really was. And certainly something that we're going to be looking to do more on. So in terms of our services, they kind of fall into 3 broad areas. One, that's my timer up, so I'll be quick. Information and advice is a really key plank of what we do. The 2 biggest areas of requests that we get are around benefits and income maximisation. And I'm really proud of the team to say that during the pandemic period and those lockdowns, they managed to access over £600,000 of unclaimed benefits that people were entitled to that they didn't know, which can be utterly life-changing. And the other area of advice is around social care and what people, how people can access that and access an assessment and that broader information. We then have our community connection services, which are day clubs in the main. So we run clubs in Bath and Midsummer Norton and in Keynsham. And we have a specialist dementia club which uses a technique called maintenance cognitive stimulation therapy. So for people with mild to moderate dementia, that can be a real positive intervention to I guess to keep people's minds active and to try and slow down progression of the illness. And we've just restarted our Singing for Fun group, which is heavily oversubscribed with Midsummer Norton, has to be said. But then Joe mentioned our support at home. So a key plank of that is our home from hospital services, supporting people out from hospital. And then we have some longer term supports that we have in place for people. One of the new things that we did, and I'll stop here, is we started to make proactive phone calls to people who are over 60 being discharged from hospital, who on the ward that they've had no further needs identified. And what we wanted to do was to put a safety net in place. So people would get a call, we check in, make sure they're all right. And I think since we started that, we've made over, I think, 1,200 phone calls. And every week there will be a number of people for whom they require some additional support. So either that's something we can provide for them, or we will link up with all of our other partners and who's best placed to do that. And that's an ongoing piece of work and vital to that kind of work across the hub. So I'll end there. I think for us as an organisation, what we're doing for the future can best be kind of summed up as trying to build an age-friendly community across Bath and North East Somerset. And I think with the Community Wellbeing Hub, with our GP partners and with the wider integrated care system, I think that's how we can start to do that. So I'll stop there.
Brilliant. Thanks, Simon. Really good, and really good to have it sort of backed up with that survey information. And thanks for sharing that with us. Really good. We'll certainly pick up some of those points later as we're going through. I'd like to now introduce, so I should declare an interest here. I've technically line managed Denise, but that's quite a challenge in a nice way. But I'd like to introduce Denise now, who's Denise Perrin, who's going to talk to us about the work of the village agents across Bath and North East Somerset, and particularly Chew Valley and the Somer Valley. Over to you, Denise.
All right, so let's see how the technology works. I've unmuted myself. Sarah, are you going to do the screen, or shall I share mine?
Yeah, I can do the screen. Just bear with me 2 secs.
I'm going to keep this short with short slides, but I wasn't quite sure the order we were going to do the presentation, so I was going to pick up on a few things. The village agents, some of you know us better than others. Let's go to slide 2 with the map, Sarah. That would be fantastic. Thank you. So we started back in 2010 with 10 parishes in the Chew Valley area, rising through in the 2012 to covering 23 parishes, and we added in some of the Somer Valley and some of the Cam Valley villages. And then more recently, slightly delayed by the COVID, unfortunately, we've managed to start Michael Alton, who's on the call tonight, as the new village agents for the Westfield, Radstock, Poulton and Midsummer Norton areas. He started in June of this year. And the good news is that we've just secured funding to take the village agents across the rest of the rural areas of Baines, hopefully November time onwards. Now, what that means really for a lot of people is, when I first started this job, I was constantly being told Bath and nowhere else. And I think there's been so many council services and Virgin Care and other services that are completely invested into addressing that inequality. And this is the final piece in the jigsaw to bring us very firmly servicing the rural areas, because we can give the rural focus, the local knowledge, the local expertise, and making all the connections that are necessary to help someone. So if we want to be person-centered, we need to meet them where they are at. And if they are in rural areas, there are very rural related issues associated with people. Even the silly things like having to do a 20-mile trip to the hospital for an appointment. How do they get there if they've got no means of transport? So right at the beginning, we helped set up a local community car scheme. And more recently, it's about making sure that as much as possible, we help people address those early warning signs that something in their lives might not being addressed. So people get very used to the environment they're living in, so they don't necessarily notice that they're not managing so well in their own home. They won't necessarily want to admit that they're needing help. But through one-to-one conversations confidentially with us, we can start to help them talk about their lives, because most rural people in rural areas, and mostly older people, to be honest, don't want to accept help, but would never admit that they were needing help. But also are so stoic that they never feel that they deserve help, or that actually, we've been living out here for so long, we just get on with it and we sort of manage, so no one else is going to help us. And slowly over the years, we've convinced people that not only do they matter very, very much, but the services are out there to help and support them. And Joe's talked about all of the fantastic services across Baines, who are all available to everyone in Baines, and the hub is just one of the manifestations of that. So next slide, please, Sarah. Some of you may remember the No Wrong Door thing that came out of all of those consultations that led to the Virgin Care contract being started. And that is very much still the approach we're all taking, which is you can talk to any one of us in this collaboration of services, and we will help you to define which is the priority for yourself, what support you might need to achieve the goals that you need to set to make your life more pleasurable, comfortable, more affordable, or whatever. And through the process of triage and then bringing in other services, specialist services, but us holding people's hands all the way through those processes. That's very, very important, because whilst some referrals through to the CAB, for instance, those processes to unravel someone's financial difficulties might take quite a while. In the meantime, we're holding that person's hand to help them look at some of the other sort of things that you might call TLC, you might call well-being, you might be helping them just to help connect with their local community, where again there's lots of fantastic things available, just a coffee morning round the corner that they never even knew about or they stopped going to, just making more of all the little local connections. We've talked about the stress and strain on the health services, and Chris at the very beginning was saying how difficult it is. So for us, most of our referrals to our service do come from people just ringing us up and saying, well, my friend was helped by you, and I think you might be able to help me, and let's have a conversation. But we also get quite a lot of referrals from the medical services. Now that might be Joe's staff out working in the community as district nurses, community matrons, the reablement teams, or physios. But that is also the GPs making direct referrals to us. And Chris makes a lot of referrals to our service from the Timsbury area. But the great news is also now in the Three Valleys area. Next slide, please, Sarah. We've got a fantastic collaboration now. This shows the connections relatively recent. So the village agents have been there for a wee while. More recently, and during last year, Tracy Bliss came on board as a social prescribed link worker attached to the Three Valleys, but actually employed by Wern. And she is taking a lot of calls from GP services to help people with a lot of the non-medical needs in their lives. It might be financial, it might be mental health, it might any number of practical and well-being issues that can be supported by her. At the moment, her caseload is quite high. I mean, she's got about 70 clients that patients that she's seeing, and she connects them to wherever they need to be connected. That might be to us, but also it might be to very local services. In the top right-hand corner of this slide, you'll see that's the team of care coordinators, and they came on board earlier this year. Fantastic concept. And I see the care coordinators who are based in each of the surgeries in Three Valleys as the go-between between patients and the medical services being delivered by the GPs. And they can have, they can do a similar job to Tracy, but also they can help someone with the complicated bits and pieces that go around continuing people's health care. I'm not the best person to tell you the details of this, and Helen's here today, she can tell you more. But that team of people, those care coordinators, and now whilst a GP has about 10 minutes, 8 minutes with a patient, the care coordinators can pick up on some of the conversations that GP has had and take them forwards, have another conversation, which is, okay, well, let's flesh out some of these other issues. It might be social isolation, it might be practical issues. And they can help then connect a patient with the relevant service. Next slide, Sarah, please. And then in the middle, we've got the community hub, who continue to be amazing. So whilst we've got no wrong door for the patients, actually it's even better for all of us as well, because we can make one call to the community wellbeing hub and start to refer someone in and say, look, this is a complex case, it's a bit of financial, it's a bit of care is needed, a little bit of housing issue. And meanwhile, the village agents will be helping to connect them to local resources. So for us, this amazing network is really, really supporting local people to get the best out of their lives. And it really shouldn't be an additional thing in your life, an extra to be in comfort and to be safe and cared for and valued. So all of these things are very, very important. And I think that's all I need to say tonight. And any more questions about specifics of the village agents, you can always come back to me.
Brilliant. Thanks, Denise. And we'll pick that up at the end. So we are now just about on time. So I'm going to hand over now to Helen Harris and back to Chris as well. And you're going to talk to us a bit more about the primary care network and the overview and what's going on at a GP level. And then if people can still remember questions, then we'll open the floor up and we'll have a bit of a round table discussion, if that's okay. So I'm going to hand back to Chris and to Helen.
Great, thank you, Chris. And Sarah, are you going to share my slides or do you want me to share my screen? She's doing it, lovely, thank you. Okay, so good evening, everyone. I'm very mindful that I've got quite a diverse audience here, so I thought I'd go back to basics a little bit with what primary care networks are all about, and then give you some headline information. There's quite a lot of information in these slides, and I'm mindful of time, so I'm hoping that they can be shared afterwards for people to read each line and digest. And I'm always very happy to take a call or an email from any of you if you've got any questions. So what is a primary care network? Well, we have 6 of them in Baines. There are 23 of them in Baines, Swindon and Wiltshire. And nationally, there are 1,250 primary care networks. And typically, they are groups of practices that are covering around 30 to 50,000 patients. But within Three Valleys, thank you for clicking on the slide there, Sarah, we've actually got 9 independent practices working together from 11 sites. And We are covering a rising 68,000 patient population. So we are almost twice the size as many other networks, and we are covering the whole of North East Somerset. So for us, and primary care networks were established in July 2019, and for us that has meant that there's been quite a focus on what we are doing, what we can do, and really the scale that we can impact on our community and patient healthcare. So it's been really exciting to be a part of that. And I'm certainly joined by a really strong practice management team, including practice managers and supportive staff. So, you know, I've got a really good team around me. So in terms of what we've done so far and what our aims and objectives are, I just wanted to go around the wheel there. So we're all about collaborative working. You know, what can we do better if we do it at scale and if we work together? So there's obviously no better example of that than our vaccination programme that many of you will have experienced at the Soma Centre. Really great experience for patients and for staff. But also we have been able to recruit a number of new staff, and they are already working within our practice teams, and I'll talk about them a little bit later on. Next slide, please, Sarah. So generally, here are bullets for our aims and objectives. So we're all under pressure at the moment. So the intention of a primary care network is to try and reduce high levels of workload in general practice, bring on more staff with a range of experience of skills that can help us. And that will in turn improve our resilience and our sustainability. And as I said earlier, we want to work at scale where that makes sense. But obviously we don't want to take any personal practice experience away from patients. That's still really important too. We want to broaden the skill mix within primary care, and I'll talk about the roles that we've onboarded already in a moment. And we want to improve the quality of care to our local population. So as Denise and Joe were saying earlier, it's really important for us to have that local feel and to really know and understand our communities so that we can either put services in place ourselves or at least champion those to the NHS and to the wider system. And I think, as I said right at the very beginning, we feel now that we've got a really strong voice in primary care because we are practices that represent everything outside of Bath, where, you know, previously we felt a little bit forgotten. So I think, you know, we are stronger together in that sense. Next slide, please, Sarah. So the primary care network service specifications are based on an Nhs Triple Aim. And many of you will be familiar with these. So it's a service focus on improving health and saving lives, improving quality of care for people with multiple morbidities, and also helping to make the NHS more sustainable and reducing expensive and avoidable hospital admissions. So that triple aim has been in place for some time and was actually the founding block of why primary care networks were introduced, so that we could work together to tackle these three priorities. And then those priorities have been broken down into 7 service specifications for primary care networks, which I've got on the next slide. And in the simplest form, although there's a lot of detail behind this, these are the things that we're going to be working towards improving in your community. So medication reviews, our treatment and support to patients in care homes, and we've got 11 of them within our patch. Anticipatory care requirements, so that's understanding how we can put in place systems to improve patient care at the earliest opportunity. Personalised care, and I think Denise's example of our care coordinators is a great start for us, and how we can utilise support from primary care network funding. Supporting early cancer diagnosis, cardiovascular prevention and diagnosis, and also tackling neighbourhood inequalities. which is a really big one for us. And we're going to use all sorts of population health management data to be able to better understand how we can improve that situation. Next slide, please, Sarah. So back to our workforce, what have we done so far to make some tangible changes to the way that we operate every day? Well, through the pandemic, and that's, it's been tough as it is, but through the pandemic, we've actually recruited 18 extra people to work across our practices. So we've got 6 new clinical pharmacists working in our groups. We've got a social prescribing link worker that can signpost patients to groups, services, activities to improve their health and well-being. We've got a first contact physio, and we'd really like to recruit more. So actually we have active ads in our area to recruit more physios who can really hit the ground running quickly and make a difference. We have recruited 4 pharmacy technicians to help and support our clinical pharmacists. We've got 6 new care coordinators, and they have really taken off quickly. And I don't know whether any of you have attended the Soma and the St Mary's, the Timsbury events that Denise organised, community groups, where our care coordinators were meeting and greeting patients and really getting involved in our community. And their remit is pretty broad, actually. So, as Denise was saying, where there's limited time in the surgery, ordinarily, the care coordinator can be brought in to really put their arms around the patient and, sort out some challenges for them and be with them every step of the way. So those are the roles in green, and then in amber there, these are the roles that we are considering recruiting pretty soon. So what happens with our the funding that we get to recruit these staff is that it increases year on year. So we can decide exactly from that list there who to recruit and where we're going to get, in effect, the most bang for our buck. And we've decided that our next focus, as well as extending and increasing some of the roles that we've already recruited to, we're going to be recruiting 2 new mental health practitioners, up to 3 new nursing associates to help with respiratory nurse appointments and flu jabs and things like that. And also a potential to grow our own nursing associates, so to recruit some trainees that we can grow and develop. So that list, as I say, is growing, and funding increases year on year for that workforce to grow and improve and to support our practices. Next slide, please. So what are we going to do next? Well, we're going to be doing more recruiting so that we can really grow that workforce. And also, I think we need to think about the room that we have available in our current surgeries, because it's all very well bringing on lots of staff, but they have to have consulting rooms, desks, computers. We're sort of implementing a whole new workforce here, and that's going to take time, and we need to get that right. So we're considering estates planning and being creative about people working from home or working in our community. And that's a conversation that perhaps I can have with some of you on the call about utilising community spaces where that makes sense to do so. For example, leg clubs in community spaces, things like that. Next slide, please. Okay, so I'm not going to read out all of these, but when you take away the slides and have a look yourself, I just thought I would list some of the successes so far, like the Soma Centre and the vaccination programme, the growing of our workforce, our real sense that we're working closer and forging strong links with our community, and also including things like our local school leaders and the school nurses. So lots of good work going on already, despite the pandemic. And, when we haven't got so much of a focus on that, I think we would just really fly with some of these things. But we've certainly put in place some strong conversations to start with, to start the ball rolling. Always open to hear from you, so please do get in touch with your ideas, thoughts and comments. And I wanted to say that also we're very keen to set up a primary care network patient forum. And I think what we will do is ask our care coordinators to lead on that. And it will be really critical to get some strong patient feedback and to really be working with our community on our strategy for the future. And that's it from me.
That's brilliant. Thanks very much, Helen. Chris, did you want to say anything at this point?
Well, I think I've got some slides to talk to. So,
Have you?
so yeah,
Excellent.
so I'm happy to go next.
Okay.
I won't
so
set a timer because I know you'll shut me off when it's time. And
Okay.
Sarah, if you could do the slides, please, because I shouldn't be allowed anywhere near IT.
No problem, Chris. I'll just get them up a sec.
Thank you. So I have to say I'm slightly disappointed to be doing this next bit because I hoped that our clinical director, Dr. Liz Hirsch, would be here to talk about integrated care systems, because I think she knows a lot more about it than I do. There's an awful lot of unknown unknowns in this at the moment. So we'll talk through some slides, but I'm not going to spend long on it, partly because I don't know that much about it, and partly because there is nothing more boring than health service reorganisation slides. And trust me, I've sat through my fair share. So next slide, please, Sarah. Okay, these are the aims of integrating our care system. And I think there's nothing on here that doesn't sound completely laudable. Improve population health and healthcare. Well, if we're not doing that, what are we about? Tackling unequal outcomes and access, I think, is really interesting. And I think that's interesting for our area because there's quite a big diversity of communities that we have. And so we might have to have some interesting conversations within our area about where does resource go. If we are sitting in the lovely affluent Chew Valley, should we be having the same amount of resources, perhaps our colleagues in Radstock? And maybe we ought to be thinking about tackling some of those inequalities. We have really good data now to base these kind of decisions on. My particular area of interest in the PCN is around cancer. And whilst all of our practices are actually, compared to the national average, very good at picking up cancer early, there are still discrepancies between us. And so we need to identify which practices need help, where there are barriers to access and for patient understanding. How do we help to get better screening done and pick up those cancers early? And that's an interesting conversation and potentially a tricky one. Enhance productivity and value for money. The NHS is an amazingly efficient healthcare system globally. You know, it is something that we should be deeply proud of for the outcomes we get for the money we spend, but we can always do better. And some of those conversations will be around how do we use technology? How do we use our consultations better? I know we have a project running on group consultations, something very different. If you're used to a one-to-one conversation with somebody, perhaps it's better done in a group, and there are certain areas where we might be using that in future. And then help the NHS to support broader social and economic development. Sounds suspiciously like levelling up, doesn't it? Next slide, please. So these are the expectations. Decisions taken closer to communities. That's a really laudable aim. I hope it happens. I'm old enough to remember that that's what CCGs were supposed to do, but it was difficult. Collaboration between partners in a place. Now, this is really interesting and really different, because if you remember all the way back to Ken Clarke in the 90s, competition was the watchword. That's gone. We now have to collaborate. We have to work together in our healthcare system. And that means that we're sharing knowledge and resources and care with people like Virgin, people like Simon in the third sector, and our colleagues in the RUH. Some interesting conversations and some challenges around funding and contracts and all sorts of things that we have to work together. And these are barriers that we have to overcome. We're not there yet, but the conversations are happening. Strategic commissioning based on population health outcomes. There's a nice little bit of management jargon, isn't it? So what does that mean? Well, we have to think carefully about what we need and where we want to be and what services do we want to commission. And that might mean some difficult choices again. We might not get everything we want, but we hopefully will get what we need. Innovative use of digital and data. I share Simon's concerns about digital divide. I've been in too many conversations where there's an assumption that everybody has internet access. And I visit homes where there's a phone and a TV and that's it. We do have to be very careful that we do not exclude our populations where they do not have access to IT technology. And you know, it's not just the knowledge to use it, but it's also the having it in the first place. Thanks, Sarah. Okay, what does this mean in practice? Yeah, I don't think we need to go on that. Let's move on from that one. Practical changes. These are really practical changes, but they're also challenges. We need to start working together with all of our colleagues. I think that's largely in place. Clinicians are pretty good about talking to one another about the things that we're interested in. And so I think those conversations, we all bring a different perspective, but those are definitely happening. Leadership, governance and accountability, very important. How do we keep the system safe across all these old boundaries? If we're going to be blurring those boundaries, we've got to make sure the safety systems cross them as well. Finances, I've talked about as being a challenge. Okay, I think that's probably it. Now, you will not be too surprised to have this up here, I think, at this time. You might be disappointed I'm not going to talk about Jimmy Greaves, even though I am a Spurs fan. We know it's hard to get an appointment. We know. My system has appointments booked up for the next 4 or 5 weeks, and I can see how many are booked up. And I know from how the receptionists battle for the melee at 8 o'clock to get the same day appointments. I was looking for some figures. The British Medical Association put something out. The most recent figures I found was July 21, and there were 17 million GP appointments in England in July this year. If you go back pre-pandemic, because 2020 will not be a good indicator, that's 1 million more than July 2019. So why is it so hard to get appointments at the moment? And I can't say I have an answer for you, but these are just some of my thoughts. So this isn't an exhaustive list, but there's a backlog of problems. There are things that people did not come to see us about during the pandemic. They didn't want to trouble us, but now they need them sorted. The second thing is that under normal circumstances, practices have targets. We have things that we have to do. So that's things like, are we controlling your blood pressure, or have you had your asthma check or your smear, or those kind of things. Last year, those were suspended, but this year, everything is back on the table. And as Helen's alluded to, there are network targets as well. So there's all that work as well as the backlog from last year. There's been a lot of staff turnover. I think the pandemic's made a lot of our staff consider what they want out of their career. And we've had 2 doctors leave us, and we've had all three of our nurses move on from the surgery in the last year. We have been able to recruit, and that's largely because general practice in this area is seen as a highly desirable place to work. People want to come and work in our part of the country, and we are immensely blessed by that. It's not true elsewhere. And some of those, you will see headlines of practices closing and patients being redistributed. Fortunately, we are not in that situation here, but it has been a big change for even quite stable surgeries to accommodate new change and to embed them in the organisations. We're right in the middle of our biggest ever flu immunisation campaign. Some of you probably have had the text messages, and we are doing that. We were working all day Saturday last week. And primary care was the most efficient deliverer of the COVID boosters. Helen said 3 Valleys did 40,000 plus jabs in the first 5 months of this year. We're working against shortages in essential materials. We can't get some drugs, and you've probably heard that in the last month or so, we've had a shortage of blood bottles. Who would have thought that we would be short of those? The situation is better. We are phasing those back in over the next few weeks, but it's been a huge challenge to deliver care to anybody but the most sick patients. We are the interface between our communities and a hospital system that is struggling just as badly as we are. The wait time for most specialities is several months. That's not good. And we're the ones who are trying to be the advocates for our patients, trying to get them seen by consultants. And everybody, after the year we've lived through, has unprecedented levels of anxiety. Symptoms that we might previously thought of as fairly minor are causing huge amounts of concern out in the community. And that is to say nothing about the actual mental health problems we are dealing with. So that gives you, it's a bit of a tsunami of need at the moment for one reason or another. We are trying to field that as best we can. And one way we are doing that is by trying to offer a better mix of telephone and face-to-face appointments. Now, I know you've heard this a million times. Telephone appointments are not the same as face-to-face appointments. And believe it or not, we do like seeing you. Most of you, most of the time, we do. That's what we train to do. And we have never stopped offering face-to-face appointments or home visits when we need to. It is really difficult to examine an ear down the phone or lay a hand on your abdomen or examine your intimate areas. We just can't do it. So if we need to, we will see you and we will fit you in as best we can. So really the only thing that has changed for most practices is just that proportion of face-to-face. We always did some telephone, it's just the proportion has changed. And I think there are benefits to having a better mix. You know, for some people, particularly those working or in school, it's actually better to have a phone call. It's more convenient to have a phone call than have to take time off and come and sit in our waiting room. And I think there are some benefits to the technology. I think the text messaging thing has been fantastically helpful. We used that to great effect during the booster campaign. And actually seeing photographs of rashes and skin lesions, and even I'm amazed how good people can get photos of their throat. They are brilliant, really helpful. And not only are they an accurate way of diagnosing a problem, that photo can stay in the notes. So if we need to see something in the future, we've got something to refer back to. So that's great. I think there are some good news areas here. I think the first thing I would say is GPs in this area are genuinely and absolutely committed to the villages and the towns and the communities we serve. And I think the Helen's put the word unhelpful on top of this. And I think that's why this headline is quite so unhelpful, because it sells newspapers to stoke a bit of division. But that's not how I see the situation. It's not why I go to do the job. The absolute joy of general practice is that we are completely rooted in our communities. We know you, and we know your family, and we know your neighbours, and you know us. And that is an extraordinarily powerful partnership to build on. There's none of us that wants to see any patient struggle to get access to the care they think they need. Our practices are assets in our community, and anything that tries to stir dissatisfaction and divide our communities, frankly, doesn't do anything to solve the very real problems. I'm a bit old-fashioned. I don't consider myself to have a job as a GP. I think it's a vocation. And I've cancelled leave this year because I could see that we were short of appointments for patients. I used to have a half day. I don't have a half day at the moment because I'm using it for patient contact. And Denise will tell you that I'm doing my paperwork at all odd hours of the day and night, and you ask her what time she gets emails from me. Sunday mornings, late at night, early in the morning. I'm trying to do the best job I can. I've shunted my admin around. So let me assure you, if you can't get an appointment, it's not because I'm working on my golf handicap. It's because there aren't enough days in the week and there's not enough resource for us to meet the tsunami of need that's out there. Every single practice in our PCN is a training practice. We do it because we like it, but we also do it because we want to train the next generation of GPs who deliver care in the years ahead. And quite often we do fill our staffing gaps with our brilliant trainees. They are really excellent in this area. They put down roots here and we want them to stay. And as you've heard, there's now a whole range of different staff available through the PCNs. There's pharmacists, there's experienced physios who are frankly far better at dealing with musculoskeletal problems than I am. There's the care coordinators, there's the social prescribers, there's the village agents. They all have the time and the skill to really get to grips with the complex social problems when the medical thing isn't really the main issue. Next slide, please, Sarah.
Are you wrapping up, Chris?
Yeah, very quick.
Nice one.
Sure, you've seen this slide before. We've always asked you to think very carefully about which service you think you need. And now there's even more choices available. So I started off the evening by promising one thing you could guarantee in the health services change. Some things remain the same. The commitments that your GP share to giving you the best care possible, that hasn't changed and it won't change. We all wondered at the start of the pandemic what the new normal is going to look like. And I think that the new normal for general practice and for healthcare in general is going to be more of a mix of remote and face-to-face appointments, greater use of technology and a wider range of appointments with other allied professionals. And I would end by challenging us all as a locality to put aside any attempts to put divisions between us and actually engage in a dialogue about what's important to us as a rural area. How do we best use the limited resources available, and how do we harness the skill and the time and the enthusiasm of our whole community to continue to care for every member of our society? Thanks, Chris.
Chris, that's brilliant. Thank you so much. And to be honest with you, I'm so pleased that we're recording this, because I think this is one of those sort of presentations where actually people need to go back and listen to it again, because actually there's so much information contained in this. This is brilliant, and this is a really good resource. So thank you to Chris for that last bit. Thank you to Joe. Thank you to Simon. Thank you to Denise. Thank you to Helen for all of the stuff that you've been explaining to us and about getting that overview. There's a couple of things that I was just wanted to raise, but we are going to go over to questions. So if you can sort of start thinking about questions, or if you've got any questions, we'll take those in a minute. But one of them was this term anticipatory care, which is a bit of a buzz phrase going around at the moment. But basically, and Helen gave a very good example of what she thought anticipatory care is. We're taking anticipatory care just to mean well-being, keeping people well in the first instance. So actually you don't need the care, so you don't need medical treatment. And I think actually what you've heard tonight is actually a really good example and really good case of where actually looking after the community's well-being is really so important. And there are the different mechanisms to put in place to look after the community's well-being, whether that's through the village agents, through Simon's work at Age UK, through the community transport colleagues that we've got on the call tonight as well, through it's a wraparound service. And actually what we wanted to do tonight, which is why we did this jointly with the Soma Valley, was to show colleagues on the call actually there is this sort of wraparound service that we've now got in place. And actually what I would ask you as people who are on the call tonight is to go out and talk to people about it and to tell them about it. So actually, when you hear something, a grumble or whatever, you can signpost them in the right direction. There is so many things going on at the moment, and Chris was absolutely right to talk about, the integrated care system, and that is a really massive piece of work. But actually, in terms of what we're doing in the Chew Valley, Soma Valley, you can let others worry about that. We will try and keep that wraparound service going for you in the Chew and Soma Valley. I think the thing about digital inequality is going to be really important. Lots of things, and the irony of us doing this on Zoom tonight is not lost on me. The fact that actually, we said that one of the good things about doing Zoom is we get many more people coming in. We don't have to bother traveling and going out in dark nights like that. But actually, we are also excluding people. So that's one thing that actually is really important. The idea about what's called wider determinants of health. So that's housing, education, finance, culture, heritage, all of those things which actually help to enrich people and make people feel that they have a better lives. That's really, really important. And Simon taught me all about about well-being when we were working on a previous project, and that's been really invaluable. And I think that's something we want to really try and pull in together. And Helen, you talked about the patient forum. Again, that's a really good case where people can actually get much more involved in what's going on, and I think feeding into the health system that you've created and that is now in place is really powerful. So I just wanted to say thank you before we start the questions. I do have a briefing that if anybody asks a question, and Chris sort of spoiled it a bit at the beginning, if anybody starts drilling down onto an issue of personal medication and personal treatment, I think we'll ask you to take that offline, and I'll give you Chris's WhatsApp telephone number so you can get him on WhatsApp later. Joking part. But yeah, if we've got any, no, I can't wait, Chris. But if you've got anything like that, we will ask you to sort of to take it offline. But I'm really happy to take any sort of general questions. And we've got about 10 minutes. I know that's really compressed considering the time that colleagues have given us so far. But if we've got about 10 minutes, we'll take them elsewhere. And people, yes, are people comfortable raising their hands? Paul's already put his hand up. So on the bottom of your Zoom screen, and I think it is the case for iPads as well, you will have, there's a button called reactions. If you just click on reactions, there's a place to raise your hand. So if you wanted to use that, and Paul's already done that, so I'm going to take Paul's question first, and then we'll bring in members of the panel as we go through. So Paul, over to you.
Okay, yeah, I'm from the Summer Valley Food Bank, and it's not really a question. It is a question to village agents as to whether they want to be voucher holders so that they can issue vouchers to older age people who are in need. If so, I'll put the email on in the chat, and then they can contact me, and we can take it forward from there.
Brilliant. Thanks, Paul. We got a thumbs up there from Michael. I'm sure Denise is giving us a thumbs up as well. That's brilliant. Thank you so much. Okay. I have got some questions if nobody else has got any questions. Stunned silence. Okay, this is a question then, just purely on practical grounds, and this is suppose for Helen and Chris as much as Simon. The Chew Valley itself, for its hospital provision, particularly looks towards Bristol, and Midsummer Norton looks towards Somerset for some of its provision. How does what you've just talked about relate to both what's going on in Bristol and to Somerset, and how do we sort of, utilize what is a complex geography, or how do we work within a complex geography to get a holistic service, given that your hospital provision for your integrated care system is going to be based around the RUH and the Great Western Hospital in Swindon and Salisbury Hospital?
Do you want me to take that, Helen? Really good and really pertinent question, Chris. And I think this is something that is very difficult for us because our current clinical commissioning group and what will become integrated care system is a product of a merger between Baines and Wiltshire and Swindon. And those commissioners who have come from Wiltshire and Swindon have no concept of the existence of Bristol. They do not have any sort of history of patients from their areas going to Bristol, and it's quite a surprise that to them that some of our patients do look westward. So unfortunately, I think the answer is I think it will be quite challenging to integrate with Bristol and with Somerset in the short term, particularly whilst we figure out how to do integrated care locally. And that will be an issue. So in terms of, I should say I have yet another hat, which is that I also work for the GP Federation, which is called BEMS. And we are looking at setting up working groups within the footprint of RUH. So that will look to a little bit towards West Wilts as well, because those practices refer more towards RUH. But Bristol at the moment, it will be doing its own thing. And I suspect for the short term, the integration will be not there because we're figuring out we're putting our own houses in order first. But I'm very mindful that that is the situation for Keynsham, some of the Chew Valley particularly, that actually, if you work in Bristol, why wouldn't you want to go there? I get that completely. I think some of the larger systems, so things like the referral system, where you can choose to go to any hospital you want to for an outpatient, I don't think that's changing. As far as I know, patient choice is still embedded in the NHS Charter. I don't think that's changing, but how we actually put it into practice, don't know yet. Does that answer the question?
Well, it was particularly related to what Simon mentioned about the out of hospital discharge activities. And again, it's a project which Simon and I have been working on in Bristol, which, is now being picked up out here. And I know that Sarah Williams is on the call from Swan, but it's this thing about how people are transported. If someone's in a Bristol hospital, they get discharge information based on the Bristol system. And how does that all kind of work?
Yeah, and if Jo's still here, she might be able to pick up, because again, the reablement service picking people up out of RUH, I don't know what the communication with Bristol hospitals is like, but Jo might be able to talk to that.
Okay, so
yeah, I mean, it's a really good question. I was thinking about it. Something that I'm surprised that Wiltshire commissioners aren't used to it, given a lot of their patients in Salisbury go to Dorset. So you'd think they'd be used to border issues, but Chris is right. The systems, no one can question the logic of how they've been set up. I mean, we look a lot more even closer to Bristol than we do to, say, Swindon. So it's a difficult one. It's something that our children's services have been grappling with for years, being registered or resident. You know, if you're actually a registered with the GP practice, or if you're resident, that changes from local authority over. So we're used to border issues, but it certainly hasn't made it any easier. So reablement, it is harder to get people out from a Bristol hospital, and the communications, you know, I'm not going to be dishonest, the communications are more difficult because you're less familiar with them, you're less familiar with the systems, you might not get the same information. We are very fortunate to have now got the integrated care record in Baines, which gives us live discharge from the discharge information from the IUH, which we won't get, you know, we don't get from Bristol. At some point there are plans to join all of them up, but I think Chris articulated it well and he said actually it's not there at the moment, and I think it will be a bit more difficult in reality.
Okay, thanks, Joe. Vic, I saw you had your hand up, but Simon, did you want to come back in on that point?
Well, I suppose it was just to back up Chris and Joe in that it is incredibly complex, but there are probably slivers of light in some of that stuff. So particularly when I think about the support that we provide, we work really closely with Educate Wiltshire, because I think it's that mute point in the IUH at any one time, probably about 50% of the people that are inpatients actually live in Wiltshire, which we sometimes kind of forget. So for the last little while, we've been supporting people out of into Wiltshire with the Educate Wiltshire. So I think it's Chris's point about the integrated care system, because actually if it does what it says on the tin, and actually the decisions start getting made locally, then actually what we can really do is focus on our local community and the needs of the people who live there. So I think I would like to think it's a work in progress. So dependent on, you know, if somebody from Chew goes to Bristol or somebody from Norton goes to Somerset, actually over time that should become, I'm an idealist and ever positive, you know, and you kind of think actually where there's a need, then we will keep working on it until we kind of get some solutions and some answers.
Okay. Vic, you had your hand up. You've been patiently waiting there, Vic. I'm going to bring you in there. Okay.
No, not at all, Chris. It's just that when my recollection is such that when they set up these health boundaries, it's done on numbers, and it radiates out from London, and so we get tagged on as Bath, North East, Somerset seems to be tagged on to Swindon and Wiltshire, and it was challenging when it was first introduced, but we were always reassured that the borders would be porous. So the overspill to go to Bristol, there wouldn't be any restriction on that.
Okay, thanks, Vic. And Vic, are you still the chair of the Health and Scrutiny Overview panel?
Yes, I am. Yes.
Excellent. So people know where to take their queries to as well, and that's brilliant.
Yes, absolutely.
Okay. I've got lots of hands now, so we're running. And look, I'm running out of time, and I've got loads of hands all up now. So I'm going to take Helen first, and then Denise.
Chris, mine's just a comment really. So I think it's really good that you've raised that, and because we're in the throes of setting up what the operating model looks like for the integrated care system, I certainly have logged that we need to make sure that we have a way to have conversations about cross-border working, because we're not alone in that, are we? You know, that's going to be happening all over the country. So I think at this early stage when we're planning what our communication channels will look like, we can certainly raise that up the line and get that involved.
Yeah, brilliant. Thanks, Helen. Denise?
I just wanted to mention that, of course, that a lot of the people that we deal with have got multiple health conditions. So it might be they've got problems with their eyes and needing to go to Bristol for their eyes, that they've got cancer care in IUH, that they're going down to Western General for something else. They're going in all directions for different things. So the transport log reflects all of those different things. So the fact is that my belief is that the care coordinators situated in the surgeries are going to be able to help talk to people when they're in this multiple head spinning situation and say, right, okay, what can we help you with to make some of that more manageable, but also speaking to Helen on other matters, that some of the services, some of the monitoring services need not stay in hospitals. They can come out into the communities. So some of those things will be less, so you won't have to send somebody all the way up to Southmead to have a 10-minute check.
Yeah, thanks, Denise. Ron, have you got a question, or were you going to, you weren't going to sum up, you weren't holding me to time, were you?
I wasn't going to hold you to time, Chris. I am a vice chairman, and I'll talk to you all later and sum up with a few comments. I'm talking slightly politically now, locally politically. How does Chris and Joanna and Helen all see things like the current development? This is not a political point. From Mendip putting 450 houses just over the border, which is quite clear those people will be using facilities, infrastructures, doctors, surgeries, dentists outside that area with no funding coming in externally for that. I mean, how do you prepare for that with 450 houses? That's probably in excess of 1,300 people.
Okay, that's I don't know which one of you two, which one of you three wants to take that. That's a hot topic, that one. Chris.
Poison chalice. I think the answer is you don't. As far as I know, whether they're across the border or not, if there's a large development, that health services are not necessarily included in the, is it section 117 or something like that, monies? So if a developer has to put money into a community, health services don't always get a share of that. So I was talking to a GP in a Bath surgery who said, we ordered too few flu jabs this year because our over 75 population suddenly went up 10% in a year. It happens and we have to accommodate it. But it's very, very difficult but them's the breaks.
Yeah. Maybe we take that one offline, Ron, if that's okay.
It would be great to have some planning around it.
Yeah,
it would be terrific to have some planning around it.
Thanks. Joe.
I was going to answer that one. I mean, I think it's a really good question from Ron, but also from Chris. You know, services are under increasing pressure all the time. The therapy services, some of the demands gone up fourfold on that. That's absolutely phenomenal. So the answer is we're dealing with that kind of thing all the time, and somehow we always find a way around it. And I've completely forgotten my question. So actually what I wanted to say also is Helen and Chris Lewis articulated well the integrated care system, and we've talked about some of the challenges, but below that there lies our opportunities. So it's trying to think more positively, like Simon. There is something called the Integrated Care Alliance. So that is the work that is done. So integrated care system, and everyone talks about the system. And then we have the alliance. That is just the Baines, Bath and North East Somerset area. That's our opportunity to say what needs to be decided at a Baines, Swindon and Wiltshire level, but actually what needs to be managed at a local level. And they're the conversations that are currently ongoing. And Liz Hirsch, one of Chris's partners who's not here tonight, she sits on the Integrated Care Alliance, as do I, and there's a first meeting, sort of planning meeting of that next week. And I'm definitely going to remember from this conversation today, Chris Head, that I will take the boundary issues in terms of the planning and the vision. I will take that to that planning meeting next week, because I think that's really important.
Chris, you had your hand up before, and I'm painfully aware that I'm now on borrowed time, so I'm at my half-past time. But if colleagues are happy, really happy for people to drop off. A couple of people have already had to leave, but we'll carry on. And I didn't want to spoil it for Ron and for Heather, who've been patiently waiting as well. So, Chris, last question from you or point from you, and then I'm going to hand over to Ron and Heather.
Two very quick points, Chris. I know how this pains you to run over, so. The first one is just to the point about porous boundaries, and unfortunately my experience is that they are less porous than you might hope. I've had rejections from Bristol hospitals because my referral is on a Baines headed piece of notepaper and not on a Bristol headed piece of notepaper. I get why, capacity issues, I understand they're struggling like everybody else, but boy is it frustrating. Second point was just to put some more emphasis behind what Simon said about rural transport. older people who lose their driving license for whatever reason, it is an immense blow to their health, their welfare, and their independence. It is a massive problem in this area. And I know we've had meetings about transport, but it was just to put another bit behind that. I'm really pleased Swan Transport are on. They are brilliant. I refer patients to them not infrequently, but it is a huge problem. And if you want to tackle one, that's it.
I think we've actually,
Jackie.
we've also got Chew Valley Community Transport hiding as a person called Margaret down the bottom, I think, as well.
Hi.
So you've got the full range here tonight, Chris, but thanks for that. Linda, did you want to just say anything? And then we're going to hand back over to Heather and to Ron to close up. Oh, sorry.
Yeah. Well, I've just found it a fascinating talk all the way through, because there was so much information that I just had no idea about. And it's really good. And I will be going on to have a look at the recordings, so make sure I haven't missed anything. So I would like to say a very big thank you to everyone who's come and given us the information today. Thank you so much.
Yeah,
Yeah.
Likewise, thank you from me. And now I'm going to shut up and hand over to Heather and to Ron, who are going to be the other part of the double act to finish this off.
Thanks, Chris. If I go first, Ron, and then you pick up right at the end.
Yeah, go for it.
Is that okay? Just to really reiterate what Linda has just said, it's been a really great informative meeting tonight. I think the speakers have just imparted a real sense of excitement and a sense of confidence too, in building on local partnership that's already working in our area, really to the benefit of the individual. So yeah, it's just been absolutely fantastic. So thank you all very much indeed. It's been a really good meeting. Ron?
Okay, well, thank you very much. Summing up these kind of meetings, especially something as complex as this, is extremely difficult at times. But when it's as complex as this, and I'm still boggling at some of the content that I got, but I'd like to thank all the speakers, but particularly Denise Perrin. Very exciting concept, the village agent thing, and something I need to investigate much more and understand much more deeply. So well done, Denise. Thank you for that. I'll maybe contact you and offline and talk about it as a counsellor. Helen's presentation is very stimulating. You've got a huge task, Helen Harris this is, and one which is going to be developing out of all proportion, I think, over the next 3 to 4 years. So well done on that. And the expression, I think Chris coined it, came around, wraparound care. I thought that was a superb comment, because it is like a warm coat wrapping around you and saying we are thinking about it and thinking about ways we can do better. And I couldn't finish the evening now without thanking Chris Lewis, the Demon Doctor. I wish everybody was as enthusiastic about things as him, and as positive and as honest. So thank everybody for coming, and I think that's about it, Chris.
Thanks, Ron. We were just going to say, for those people that are still on the call, just in case you are interested, we're going to revert back to being a Chew Valley Forum and a Soma Valley Forum in November. We've got a Chew Valley Forum meeting on Tuesday, the 23rd of November. And then there's a Soma Valley Forum meeting on Thursday, the 25th. So we're going to be reverting back. But I just want to say thank you so much for everyone for joining in on this as a first joint forum meeting in this kind of way. I hope it's been really useful, and we may be doing another one in the future. But thank you all very much, and thank you to colleagues who are still at work as well. And I know they know who they are, but thank you to those, and we look forward to seeing you all again soon. Okay, thanks, guys.